Hello and welcome to World Bronchiectasis Day 2022. My name is Richard. I'm a physiotherapist on the OzPIPS Advisory Board, and today we're going to be celebrating World Bronchiectasis Day. And this presentation is just an informative one, just to make sure that everybody is aware of everything that we need to be aware of around bronchiectasis and how it affects PID or those sufferers of PID, and anything that we can do about it from a non-medical point of view. We respectfully acknowledge the Wurundjeri people of the Kulin Nation, who are the traditional owners of the land on which we meet in Melbourne's East and Outer East, and pay our respect to their elders, past, present, and emerging. We also acknowledge and respect the traditional owners of the lands across Australia, their elders, ancestors, cultures, and heritage, and recognise the continued sovereignties of all Aboriginal and Torres Strait Islander nations. For the first time this year, the global lung health organizations have joined together to declare July 1st World Bronchiectasis Day and to raise awareness of bronchiectasis and its increased prevalence in many countries. Bronchiectasis is a lung disease that affects hundreds of thousands of people worldwide. But certainly we can go further and say that bronchiectasis should be something that those sufferers of PID should be looking out for. PID accounts for 1 to 17% of etiologies or causes of patients with bronchiectasis, and it is the most frequent non-infectious respiratory complication of PID, and making its pathophysiology or its underlying cause unclear and unrelated to the occurrence of these previous pneumonias. Usually with bronchiectasis, that needs to be a previous pneumonia which kicks off the process of bronchiectasis. However, with PID, you can get it without the pneumonia. The improvement in medical management, especially recently with immunoglobulin substitutions, has allowed us to decrease the prevalence of bacterial pneumonias and death rates or mortality. Bronchiectasis is not only about pneumonias and about hospital and about longevity. It's all about the symptoms, and the main symptoms that bronchiectasis can give you is an increased sputum load, increased shortness of breath, unfortunately decreased exercise tolerance and fatigue, which, as you all know, can be symptoms of PID as well. But what is bronchiectasis itself? So it's a chronic lung condition. Chronic means lasting more than 3 months. And it's the abnormal, so not normal, irreversible dilatation of the bronchi. So what that means is that the airways themselves, because of this process of inflammation and destruction, actually get wider rather than narrow, which is like a lot of other conditions like asthma. So the acute or chronic inflammation and infection causes this, and that's where medical management aims to reduce that. So the damage impairs what's called the natural drainage of bronchial secretions. So we may think, oh great, our airways are wider, that sounds amazing, so all the phlegm can fit through. But actually when we cough and when we huff, when we breathe out, certain parts of our airways actually need to narrow down in order to push that sputum out, but like a blow dart out of a blowgun. It needs to narrow down. And in that area where you have got this dilated airway, then this dynamic compression, as it's called, does not happen, and therefore you get this pooling of secretions. These secretions can then become chronically infected and resulting in this chronic inflammation and infection and progressive lung damage. So actually in the lungs, usually would be an initial infection would cause this inflammation. Now when you get inflammation and infection, we get all of the immune system sending lots of lovely things to the area in order to fight the infection. This is obviously impaired in PID as per definition, and so it varies according to all the different pathways depending on which pathway of the immune system is compromised in your particular PID. But what this means is that where usually the inflammation would then become what we call resolved at the end of the infection, the inflammation keeps going round, which then causes impaired mucociliary clearance, like we've mentioned, because of the dilatation. Then the airway mucus the airways start to produce more mucus in response to this. This leads to this pooling and microbial colonization, which means that you have bugs in your lungs, even if you aren't actively sick. And then you get this dilatation, which causes inflammation, which causes it, and we keep going around in this vicious cycle. But bronchiectasis, although it sounds so far pretty dire, bronchiectasis is it's very manageable. Now, it's not treatable. It is a chronic disease, which means that once you have it, it doesn't go away, and the damage that you may have sustained will not improve. However, we can certainly arrest any further damage, and we can certainly improve quality of life, as what we'll be talking about today, and how the symptoms impact that quality of life. So that what we call the 5 pillars of bronchiectasis management, we need to have good complete medical management, and that may involve puffers, it may involve steroids, it may involve antibiotics. It very much depends on your particular bug and particular brand, particular PID, and so your doctor is best to lead on that. And then there's management of comorbidities. There's certain things which certainly lead on to more prevalent bronchiectasis. The main ones being something called post-nasal drip, 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 drip at the back of your throat when you get the sinus infections, and doing something as simple as washouts can really help with that. And then there's management of reflux, gastroesophageal reflux disorder, GORD or GERD if you're overseas, so the prevalence or the amount of times that it shows up in a bronchiectasis patient is far higher than those without bronchiectasis. So this shows us that what we need to be doing is we need to be managing this. Sometimes what we call silent reflux, which is where you're refluxing without getting the heartburn and getting the symptoms which tell you that this is happening, but it can be setting up repeated chest infections. One of the main things is to remain hydrated. Now, hydration is extremely important for anybody with lung conditions, but especially those with any lung conditions where there might be a lot of sputum, because essentially your body will rehydrate itself from whatever source is available. So if you haven't drunk enough in a day, your body, your cells in your airway walls, etc., will look for water, and where it will find it is a sputum, and it will take the water out of the sputum and therefore leave very sticky, horrible secretions, phlegm behind, which is then hard to move. And as we can see, once that doesn't move, then it causes the damage. Now, once that has happened, we can actually do active airway clearance regime, and this is where physiotherapy really comes in. So there are certain techniques, certain breathing techniques, certain things to blow into, to do on a daily basis, which then gets that pool of secretions moving. Secretions or sputum or phlegm, it's not a bad thing. It's part of our defense mechanism. We really like phlegm. It's a good stuff. It's good. But phlegm that moves is good. Phlegm that does not move is bad. So we need to get it moving. And so an airway clearance regime is a very simple thing to do. It's not too time intensive. It's easily taught, and it should be a mainstay of anybody who has bronchiectasis. And then there's exercise, what we call the pulmonary rehab model of exercise. Pulmonary rehab is a fantastic evidence-based researched program which has been running for decades, mainly in emphysema and chronic bronchitis, but we can certainly see that that same model of care or model of exercise works really well with bronchiectasis patients. So the physiotherapy role within bronchiectasis is not, obviously we have the medical management and we have the psychology, but then from a physiotherapy point of view, we've spoken a little bit about exercise advice, management of lung and breathing symptoms, which we're going to talk about more, but then there's also close liaising with the medical and allied health teams. So just touching base with a physiotherapist, doctors are excellent at looking at the medical and looking at the diagnosis, and a lot of them and a lot of doctors will look at quality of life and other things, But a physiotherapist, their primary goal is to improve your quality of life, and therefore will take usually and often a more holistic view, and to be able to work closer with the wider medical team and the wider team like occupational therapists and speech pathologists, dietitians, other physios like women's health physios if there's any incontinence, etc. And so having that person to liaise is really excellent. The other thing is goal setting and motivation. Physiotherapists are particularly trained to be reviewing on a nice regular basis to set those goals, to set up motivation, to actually see tangible improvements in both symptoms and quality of life. So respiratory physiotherapy is another term for airway clearance. So airway clearance techniques, management of breathing pattern dysfunctions, pulmonary rehabilitation, all of these things. So essentially, so physiotherapists will be involved with anybody who has a dysfunction of any kind or a disability of any kind, and in this case, it's part of the lungs, which is what respiratory physiotherapy. Airway clearance or airway clearance techniques have a fantastic evidence base. There have been multiple reviews, and it is very well accepted that all those who have a diagnosis of bronchiectasis should be seen by a respiratory physiotherapist. An airway clearance technique should be taught and individualized to that person, and it should be done on a regular basis. But what would be the actual improvement? The main improvement that we see is something called cough-related quality of life. We know that, so you're already coughing up phlegm, but it's just really hard to cough and clear, and you don't cough it out when you want to. So you might have a coughing attack at the gym, or you might have a coughing attack at the supermarket. And especially these days in a post-COVID world, anytime you have a coughing attack, people move away from you. People don't want to see you. They pull their kids away. It can be very isolating, a cough. So therefore, this is what we call cough-related quality of life. As I always like to say, if every time you laughed, you had a 5-minute coughing fit, you wouldn't go out to lunch with your friends. You wouldn't go to a comedy show. You wouldn't enjoy family gatherings. It would just be too much of an imposition or too embarrassing. Whereas when you do an airway clearance therapy on a daily basis, the idea is that you are able to clear the majority of your phlegm during those sessions, and therefore then you don't have any phlegm to clear when you're out to lunch with your friends or when you're at the theatre, and therefore you get that quality of life back. You are back in control of your cough, and that is the main reason to go and see a respiratory physio in particular. There's lots of different methods of airway clearance. Some of the most common, especially in Australia, some called ACBT, which is a breathing technique which doesn't involve any equipment, and it utilizes the different lung volumes that we have to start to move the phlegm out of that pool up into the top airways, ready to cough out in a far more efficient manner. Now, what we can also add to that, you will often hear people talking about a flutter. A flutter is a device where when you blow into it, there's a ball that goes up and down rapidly, and it vibrates the air going back as it comes out of your airways and out of your lungs, and therefore it moves the phlegm up. Other ways to do that is to use water, some called bubble PEP, and this is called an a cappella. So all of these different methods of airway clearance are quite largely dependent on what's available. It's dependent on what your preference is, and it's sometimes there's a little bit of trial and error, but that's something to work with your physio on. Some people utilize several different techniques at different times of the day, or different times of the week, or different times when they are unwell versus not well, and so just talking with your physiotherapist is extremely important. When we talk about quality of life, we're talking about something called health-related quality of life, a person's satisfaction or happiness within areas of life that are affected by health or health care, and it's measured through validated questionnaires, but it's individual to each person. And we often split these into different domains: physical, psychosocial, coping, etc. and health-related quality of life in PID. So we already have bronchiectasis, and we know that health-related quality of life is low in bronchiectasis, but it's further decreased in those with PID. So certainly effective management of all chronic disease such as PID is necessary to improve health-related quality of life. And PID shows lower scores in functional, self-esteem, and family activities, and CVID perceived health-related quality of life to be worse than heart failure or even diabetic patients. And even in children, we're seeing a lot of reduced quality of life, especially in the psychosocial domains. There's increased anxiety, depression compared to children with juvenile idiopathic arthritis and against the healthy. And the parents' response is similar in PID to JIA, but it's worse in the healthy. So mostly in physical functions domain. So what does that mean? It means that parents of these children, whether they have PID or something else, they see their children as a similar level of disability, whereas the children themselves with arthritis do not perceive themselves as disabled or perceive themselves as having a low quality of life, whereas PID do. So there must be something additionally psychosocial about that. So why is it worse? So why is quality of life worse in PID? We see a fear of exposure to pathogens, certainly limits community access. If you know your immune system is low, and especially in the last 2.5 years, if you know your immune system is low, you will not go out to the shops, you will not go out to crowded areas, and then you lose that community access, you lose that touch. So we also get a lower prevalence, so lower levels of support, as in PID, you get lower levels of support and increasing misunderstanding of their diagnosis, especially around things like fatigue. It's the most prevalent limiting symptom, and therefore, just if somebody doesn't understand what PID is and understand what fatigue is, and you have to cancel yet another set of plans because you simply can't make it, then you have this misunderstanding of the diagnosis, misunderstanding of things, and therefore that quality of life decreases a lot quicker. So certainly exercise in itself, so apart from airway clearance, is very important. We all know that, we all see that. But the trouble is that exercise in bronchiectasis and exercise in PID comes with it fatigue and breathlessness, and it becomes a really difficult thing to achieve in this modern world where we see everybody on TikTok and YouTube is doing sit-ups and 500 pull-ups and all sorts. And we think, well, if we can't achieve that, then well, what are we doing? So we need to think, okay, what can we actually do? What is going to be the most amount of reward for the least amount of effort, basically? And what can you use your energy for, which is going to produce that reward? So we know that exercise in bronchiectasis, we use this, again, this pulmonary rehabilitation model. And it can be an individual exercise program, and we know that it improves exercise capacity and quality of life in a similar way to airway clearance. It reduces something called dyspnea, which is the feeling of breathlessness and fatigue. And when we combine it with an airway clearance program, we see an improvement in quality of life. The other side of the coin is that we can see that there are benefits to exercising for those with PID, so with or without bronchiectasis. Certainly, unfortunately, at the moment, research-wise, there's minimal evidence, specifically in PID. Is lovely physical therapist called Kerry Sowers over in the States who's doing a lot of work in this area. There's some upcoming studies in Melbourne, but certainly what we know so far is that we can see that there is an improvement and that the initial results show that exercise in those with PID is safe. And so therefore there are no detrimental effects. And as we all know from all the research in COVID, etc., the first thing to do is check that everything is safe. However, there was initially somewhat a decrease in health-related quality of life with increasing unsupervised exercise levels. But this was thought that an increased awareness of limitations may be triggering this. And so therefore it must be coupled with education, support, and long-term goal management. So I would encourage everybody with PID and those with bronchiectasis especially to consult with a physiotherapist to really work on those goals, really work on those appropriate limitations, appropriate exercises to really set things out, because any sort of setback can be really detrimental. So the current advice in education is for those with PID is adapt from other chronic disease rehab structures, secondary immunodeficiency conditions, and chronic fatigue syndrome. So certainly we can certainly base any of these exercise programs on pulmonary rehabilitation as well. What is a pulmonary rehab model of exercise? What we see, we have some aerobic exercise, 30 minutes, 3 to 5 times a week, and some called moderate intensity, which we'll talk about. Then there's some resistance and strength training. Now, this is very simple, low weight, high repetition. So you have sort of a 1 or 2 kilo weight, not a 10 or 20 kilo weight. And you're just doing some biceps and some chest press and some squats. And what this does is improves the muscle efficiency and the uptake of oxygen to those muscles, and therefore improves how you feel about your breathing. Then a lot of people who have a chronic cough will end up with spinal issues, and this is because of the actual cough itself, which will impact the abdominal muscles as you're coughing, and the abdominal muscles, the diaphragm, your pelvic floor, and some of your back muscles will set up sort of a cylinder, so they all interact with each other. You can't affect one without the other. And so therefore this cough will absolutely limit your spinal mobility and therefore your posture. And so this is a very individual thing. Some people need full posture correction and control. Other people simply need some advice, but it needs to be included. The intensity of the exercise is an extremely important thing to consider, especially for those with PID. We know that example, though somewhat inconclusive literature in exercise and immunity in healthy adults shows us that there's what's called a parabola, which is a curve that looks like this. So we have our intensity of our exercise, as in very low intensity exercise, very high intensity, and then the likelihood of getting an infection at that point. And what we see is that under exercising and over exercising have a similar rate of infection, let's say, whereas this moderate intensity exercise boosts immunity, but it does not compromise it. So when we get to the intense exercise, and we'll talk about what that means, when we get the intense exercise, there's actually something called the open window theory, which means that for about 3 to 8 hours after intense exercise, your immune system is further compromised, and at that point, you are far more likely to succumb to any viruses or bacteria that might be in your system or might be in the area. So it's extremely important to not overwork and not underwork. And again, this is where your physio can really guide you. We really need to talk about fatigue as well, because fatigue, like I mentioned earlier, is a very limiting factor for those with PID, but also with bronchiectasis. More with PID, and it's really it's such a misunderstood symptom when it comes to exercise, and especially from the outside, it's very much, it can be seen, oh, can't you just get over it? Can't you just try harder? And fatigue is simply, it doesn't work that way. It is not effort based. It is literally the battery is low. There is no more power, and so so we need to take this pulmonary rehab model of care that we've already been talking about, and then we need to add in lots of pacing, lots of rest, being realistic about what we're going to achieve, still positive and optimistic, but realistic, and look at what's called a stepwise symptom management. So we build up over time. There's a lot of social pressures. Like I said, I just simply put exercise for health into a Google search in images, and this is what comes up. You can see, and I guarantee all of these people, maybe they can do this for the video, but all in all, they have not only just started exercising, and this is what we are bombarded with each and every day that if this isn't the way you're exercising, then you're not exercising. And this is completely untrue. We can absolutely exercise far more appropriately for ourselves, and the appropriate level of exercise is what we're after for anybody with bronchiectasis or PID. So we have this cycle where you say, oh, you get told, well, yes, you have to exercise. You see that all the time. You see it on social media. You see it on your doctor tells you, your physio tells you, and then you try to keep up with society. You're not able to do that due to fatigue, so you feel like a failure, feel inadequate. Sometimes we seek help and validation, but where do we find it? We find it back with YouTube, and we find it back with the doctors, we find it back with those who are simply telling us to get over it. Then we try to keep up, and we just get this cycle of failure and the feeling of inadequacy. So what we need to do, yes, we need to exercise, but the correct exercise for me. Who should we be listening to? We certainly shouldn't be listening to YouTube. We should be listening to social media about what's appropriate for you. Yes, fair enough. Motivation, entertainment, uh, just inspiration, fantastic, but not actual exercise programs. The correct intensity of exercise is extremely important, which is where your physio can guide you. The feeling of inadequacy and failure, we talk about something called SMART goals. SMART goals are specific, measurable, achievable, realistic, and timed. And this is in a real good evidence-based way of breaking up goals into very manageable bite-sized chunks so that we're able to achieve them as we go. And then there's seeking help and validation. So where do you get your validation? Hopefully from yourself, hopefully from those who love you, and we need to break that cycle. So extremely important, as I'm sure you've seen, is the intensity of exercise. And you can actually start to monitor that yourself. This is called the Modified Borg Dyspnea Scale, and it's an excellent scale which all good physios should be using to monitor when anybody has any breathlessness or any fatigue, and monitor how intensely you exercise. And as you can see, we put a 0 to 10 scale and then some descriptors. So 0 is nothing at all, so you're not short of breath at all. 10 is maximal, as in you have to stop. There's no way you can continue. And then we have descriptors along the way. Now, in order to exercise at a moderate level, you want to be at a 3 to 4 out of 10. That's where you want to be. That's your training zone. So if you ever describe your breathlessness while you're working as severe, then that is too much. You are then starting to reverse any of the good effects that you're having. You might even be damaging yourself. So at that point, you need to ease up a little bit, slow up, maybe have a rest, let your breathing come back down within the zone, and then carry on. On the other hand, if you would only describe your breathlessness as very slight, you aren't training enough, and you need to either speed up or increase the intensity up until you're within this training zone. And that is the most important thing from a walking, talking point of view. So in summary, bronchiectasis is the most common respiratory complication of PID, and it changes in the airways lead to collection of mucus and an ongoing cough, which impacts your life. Regular airway clearance and exercise assist to reduce this impact and regains quality of life. So if you have a persistent cough, start with your doctor, but make sure to ask for that physiotherapy referral. Thank you.